Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. Today's episode features content from an educational program titled Contemporary Management of HIV, Integrating New Data from IAS 2021. During this podcast, Dr. Eric Daar, Chief, Division of HIV Medicine at Harbor-UCLA Medical Center and Professor of Medicine at David Geffen's School of Medicine at UCLA in Los Angeles, and Dr. Shobha Swaminathan, Associate Professor, Division of Infectious Diseases, Department of Medicine at Rutgers, New Jersey Medical School, discuss key data from the IAS 2021 conference. For more information about Dr. Daar and Dr. Swaminathan, and for a link to the full online educational program, including downloadable slides specific to today's podcast, please visit the link in the show notes for today's episode. Now, let's get started and hear what Drs. Daar and Swaminathan have to say about key data from the IAS 2021 conference.
Good afternoon, good morning, and good evening to everyone who are attending this webinar. And I'd like to welcome you along with my co-presenter, Dr. Daar, to review some exciting data that came out of IAS 2021. As you can see, some of the topics that we will be covering are some information about impact of HIV on persons hospitalized with COVID-19, some novel therapeutic agents, along with 2 drug strategies. So as you can see, the global clinical platform, this slide shows de-identified data that was collected from persons hospitalized with COVID-19, accumulated by the WHO from countries all across the world, from January of last year to April 29, 2021. As you can see, they analyzed data from almost 170,000 persons hospitalized for COVID-19 all over the world. In those, about 15,552 were, or about close to 10%, were diagnosed with HIV information. But we only have ART information for about 40% of those hospitalized with COVID-19, for those with HIV. This study looked at some descriptive and regression analysis to try to figure out, what were some of the demographic and clinical characteristics of persons with HIV who were hospitalized for COVID-19. As you can see, the mean age was about 45 years, and about 37% of them were male. As I mentioned, 95% were from South Africa. So this slide depicts the prognostic factors associated with persons with HIV hospitalized with COVID-19. As you can see, the graph on the left shows the association of HIV status with COVID-19. As you can see, being diagnosed with HIV and being hospitalized with COVID-19 was independently associated with worsening COVID-19 disease severity. Additionally, when you look at the graph on the right, it's clear that being HIV positive was also associated with a much higher in-hospital mortality if you were admitted with COVID-19. Now, because 95% of the population was from South Africa, the authors also conducted a sensitivity analysis by excluding the participants from South Africa to see if the data still held true. And even when you remove participants from South Africa, being HIV positive was independently associated with both worsening with a worse COVID-19 severity disease and also a higher in-hospital mortality. When they looked at some of the other factors that were also associated with worsening outcomes were older age greater than 65, male sex, diabetes, and hypertension, all of which have been associated with worse disease outcome in persons without HIV, but also appear to be just as impactful in persons with HIV infection. And so with that, I'd like to invite my co-presenter, Dr. Daar, to see if, what his thoughts are about these data and how you might try to talk to your patients, particularly in this day and age, given the surge that we have with the Delta virus, with respect to counseling them about trying to be safe. And what do you think about the disease severity in persons with HIV?
Yeah, no, I think this was a really important study that got a lot of attention from the meeting, because those of us who are taking care of people with HIV have sort of been struggling a little bit with how much increased risk are our patients. And, the guidelines tried to weigh in initially, but it was really based on no data. And, I think we all have a general sense that people who have advanced disease are probably going to be at higher risk. The question is, what about everybody else? It's probably a continuum of risk. And I think this particular study, along with some other emerging data, really does suggest that people with HIV are a problem if they get infected. And this has lots of implications. But for counseling our patients, we obviously want to encourage them to do the most important thing they can do to protect themselves, and that's to get a vaccine. So we're strongly encouraging that. And now with more widespread availability, at least in the United States, most of the patients in our clinic that are interested in getting a vaccine have gotten it. So I think that's probably the most important message, is that in general, there's clear evidence they're at higher risk. Rather than getting into the details as to whether there's select populations, right? One of the key points from this study was that they don't have a lot of data on CD4 and viral load and antiretroviral therapy use, which makes it hard to tease out, well, what about the person who's stably suppressed or stably suppressed with high CD4s? I think we would all agree they're probably at less risk, but since the path towards the best outcome continues to be vaccine, rather than to get into those subtleties, I think we can use this kind of data to reinforce the message that we're giving anyway. The other point I was going to make, and I'd love to hear your thoughts, is that there was another study, I can't present everything in these webinars, at IAS, from a group of Spanish hospitals. And one of the interesting observations, it also had many limitations, and the sample size was considerably smaller. But one of the interesting observations was they did note that people with lower CD4s were at higher risk for progression, but only if their viral load was detectable, which kind of goes along with our experience, right? Those poor immune responders whose CD4s aren't that high, if they're virologically suppressed, their likelihood of developing complications is pretty low. So viral suppression, key message, and vaccination are the others. And that's sort of my approach. What do you think?
I agree. And I think that's what we have seen anecdotally, both in our healthcare facility as well. And even when you step back, even pre-COVID, I have a lot of patients who are really obsessed over their CD4 cell counts, particularly the ones that are taking their medication. And there are some, as we know, when their native CD4 was really low, even with effective viral suppression, many of them don't always mount a robust CD4 response. But I always tell them the most important thing, as you mentioned, is staying virally suppressed. Because a person who is stably virally suppressed for a prolonged period of time, immunologically is quite different, even if their CD4 is, let's say, 150, as compared to a person who's virologically unsuppressed with the same CD4, even a higher number. Because the virus does do a lot of things in the background, including a lot of ongoing immune activation, which I hypothesize also interplays with how COVID-19 impacts the host. And I think what the most current thing, and we was just talking amongst our colleagues this morning, is now trying to reformat our communication strategy with the revised guidance that came out this past weekend about the third dose for immunocompromised patients, including those, and their terminology is advanced HIV. And so we have to try to, they don't define it very well. They say virally not suppressed or untreated. So it leaves it, but I think we have to use our clinical judgment. At least those whose viral loads are high with or without low T cells should probably be among the first to at least get recommended for a third shot in my HIV clinic. How are you approaching that?
Yeah, and actually, before I respond to that, the other thing I was thinking about as you were talking about the issue of how we discussed it, this data, especially because it got so much attention, it is really important about viral suppression. It's really important about vaccinations in general before we even get to the third dose. The other thing that also reminds me is that the traditional COVID risk factors that were illustrated so nicely in this study, many of our patients suffer from, right? Obesity, cardiovascular disease, renal disease. So it is also another opportunity to remind them that these issues are important not just for their general health, but also if they were to acquire COVID, and reinforcing that they manage these comorbid conditions as well. With the vaccine, I completely agree with you. They weren't particularly helpful in defining the population. I think at a very minimum, we're having the same discussions that you are, and patients are calling, just as you're experiencing, asking who gets the third dose or who should get it. And, I think at a minimum, people with low T cells and detectable viral load are probably at the very highest risk for not having had a good immune response to vaccination. And that's really what this is all about, is to try to target the people who may have had an attenuated response. Because right this morning, we hear that there's talk that perhaps they're going to start recommending vaccines for people after 8 months, the mRNA vaccines.
Yes.
And I think people need to understand it's a little bit apples and oranges. The initial change that came out last week, how quickly things happen, was really focusing on groups that were at high risk for not having had a good response to the initial vaccine, and recognizing the data, particularly with transplant patients, that a third vaccine really does boost those responses. Where this 8-month number, if this comes true, is probably more focusing on issues of waning immune responses. So right now, the discussion we're having is really focusing on who is likely to have not had a good response up front. And we know people with HIV, with advanced disease and low CD4s don't respond well to pneumococcal vaccine and hepatitis B vaccine. And there's not a lot of data with the COVID vaccines, but there's every reason to believe they may not respond as well here. So I like your thought, low CD4, high viral load for sure. I don't know exactly what to do with high CD4 with detectable virus. They're probably at somewhat increased risk for having a poor response. And I really don't know what to do with those people that you were describing with the low CD4s with undetectable virus. What kind of response? I think we're in the dark a little bit. Probably we can afford to be flexible with our patients. We think the risks are low. We fortunately have access to vaccines in this country. I mean, we need to be careful and remember that most countries don't have access, and we don't want to waste vaccines, but I think we can be flexible too. Have you guys come up with any specifics that you're thinking about implementing, and any sense as to how flexible you'll be for those patients who are calling and saying, I may not fit into your group, but I know I'm at high risk or I'm worried?
So I think we are going to be quite flexible for the simple reason that this morning, the news broke, as you said, the New York Times reported that everybody is going to be recommended a booster shot. So just to kind of separate, the CDC and the FDA guidance last week was actually a third dose because it wasn't a booster. Technically for them, that was part of their primary series. Because in the solid organ transplant recipients, where there's the bulk of the data, only 50% or so in most of the studies had an adequate immune response. So the third dose was really sort of part of their primary series of vaccination. So for those groups, you'd be and it's really kind of the honor system because, it's really not reasonable to expect patients to come and to give proof of their immunosuppression or their cancer-free. It's not very practical. So at our institution, we are going to be quite flexible. I mean, we're going to have to take people at their word. My priority is still trying to get those who are not vaccinated yet. In fact, every week for the past week, I've escorted one patient down to the vaccine center on site. Let's just go, because I had a couple of no-shows and I said, they were on the fence and we talked and they said, okay, I'll do it. I'm scared. I said, don't be scared. I'll come with you. Because sometimes they just need the extra push to get them over the fear in the social media landscape at this point.
I love that approach.
So let's shift gears a little bit and review some of the data with the 2-drug regimen. So as you can see, this is the TANGO, and I love the names that come up with some of these trials, and I have to figure out ways to remember. And I was like, well, it takes 2 to tango and 2 with a TAF-based, T for TAF-based regimen. So as you can see, the TANGO, these are 96-week data. The TANGO looked at participants, adults with confirmed HIV RNA who were suppressed less than 50 copies per ml for more than 6 months on a stable TAF-based regimen. They couldn't have prior virologic failure, no prior NRTI or INSTI resistance. INSTI is integrase strand transferase inhibitor resistance, no hepatitis B virus infection or hep C infection requiring therapy. So those were the people, and they were randomized 1-to-1 to either continue their TAF-based, ART, or they were switched right off the bat to the dolutegravir 3TC 2-drug regimen. And there were about, 370 or so participants in both arms. And they looked at week 144 and 196. These data are covering the week 96 post-hoc analysis of switching to dolutegravir versus continuing 3. And if you were confused about the 4-drug, remember, some of these people were on boosted TAF-based regimens with using cobicistat or ritonavir, if that was the case. And hence you have the 4-drug. The dolutegravir 3TC 2-drug regimen met the primary endpoint of non-inferiority in maintaining virologic suppression versus a TAF-based regimen at week 48 using a non-inferiority margin of 4%, which is a quite tight margin to document your endpoint. And they looked at a post-hoc analysis of looking at both viral replication and the inflammatory markers. So these are the virologic outcomes at week 96 using the FDA snapshot. And looking at the bars on the left, if you can see the virologic failure was about 13% or so of the participants. And if you look at looking at virologic success, which is what you're frequently accustomed to looking, and target not detected, that's what TND stands for. It was comparable between the two groups. It was about 73% in the two-drug dolutegravir 3TC and 68.5% or 69% in the TAF-based ART. There were about 13 to 17% of patients who had no virologic data, so either lost to follow-up or had other reasons for them not being able to count. So great that the two-drug regimen was comparable with respect to the primary outcome with regard to virologic failure and virologic suppression. When they looked at the protocol-defined confirmed virologic withdrawal, which was defined as 2 consecutive viral loads greater than 50, with at least 1 greater than 200. There were 0 in the two-drug arm and 3 in the TAF-based. Of note, interestingly, there were no NRTI or INSTI-associated resistance at baseline or at failure, any of those 3. So it's reassuring that even though they failed, they did not fail with resistance. There were about 7 participants who had some pre-existing archive mutations, but who maintained suppression. And 3 of those 4 patients were on dolutegravir 3TC. And 2 of the 3 on the TAF-based ART ended up with target not detected at baseline. And we'll get into that importance or lack thereof at the discussion slide. So looking at the inflammatory markers, and I know we've looked, many studies are now increasingly looking at these inflammatory markers, D-dimers, C-reactive protein, IL-6, soluble CD14 or soluble CD163. In a sense, switching from a 3 or 4 drug-based TAF-based regimen to the 2-drug dolutegravir 3TC-based regimen really didn't seem to have an impact on inflammatory markers. That's the bottom line. None of those, there was no statistically significant differences in any of those. Similarly, looking at the metabolic outcome. So does changing from the 3 or 4 TAF-based regimen to the 2-drug regimen have a favorable impact on the lipids? So let's look at it. So we have impacts on total cholesterol, HDL, LDL, and triglyceride. And uniformly, you see this decrease right at week 144 when they were switched to the 2-drug regimen, occurring at the same time as when there was an increase in the lipids in the TAF-based ART. Additionally, when they looked at mean weight changes from baseline with dolutegravir versus TAF-based ART, weight gain was about 2.2 kilograms versus 1.7, so seemed almost comparable. When they looked at other metabolic parameters like a baseline glucose, it was not that different. There was no change in the 2-drug versus there was a slight decrease, maybe 0.1 in the TAF-based ARTs. And there were no statistically significant differences in the insulin resistance by HOMA-IR. So, the take-home point that I see from this is that when they switched from the 3 or 4 drug to the 2-drug, there was generally a favor to the lipid response. So switching slides a little bit, going on to one of the next data, looking at SALSA. And this is, again, another switch study. The difference is that this was, again, switching patients, persons with HIV who were undetectable, less than 6 months, but greater than 3 months on any uninterrupted 3-drug ART, as opposed to the TANGO, in which everybody was on a TAF-based regimen. In this, you could be on any 3-drug ART. You couldn't have prior virologic failure and no documented NRTI or NC resistance, and no Hep B or hepatitis C. And participants were switched to the 2-drug dolutegravir 3TC or continued on whatever they were on their 3-drug ART regimen. And the primary endpoint was looking at participants with a plasma HIV RNA greater than 50 copies per mil at week 48 per the FDA snapshot analysis. As you can see, the baseline participant characteristics were quite comparable between the two groups. About 55 to 65% male, about 60% white, 18% Black, with a median age of about 45 years. So when you look at the virologic outcomes at week 48 using the intent to treat analysis, it's quite clear. The bar on the left, the HIV RNA primary endpoint greater than 50 was less than 1% and 1. So again, very, very small numbers. And when you looked at the key secondary endpoint, the proportion of patients who remained undetectable at less than 50 copies per mil was almost identical, 94 and 93%. There were a small group of patients for whom no virologic data were available. That was very small. And so when you looked at the differences in proportion of participants with an HIV viral greater than 50, as you can see in the bar on the right, it was non-inferior. So dolutegravir plus 3TC is non-inferior using a 5% non-inferiority margin. And it remained identical even when you increase that to about 12%. So even when you make it very strict, the switch was quite effective. Additionally, there were no resistance mutations or confirmed virological withdrawals observed through week 48. Again, very important. So we've established the efficacy. So let's look at the safety and tolerability of the switch in this group. When looking at adverse events, as you can see, overall, the proportion of adverse events was almost identical, with 73% with about in the switch arm compared to about 70% in maintaining. In general, from experience, whenever you have participants switching ART, anecdotally, whenever there is a switch, there is usually a slight uptick in the adverse events reported, in a large part because whenever there's a change and participants experience any symptoms, it is logical to attribute it to the change, regardless of whether that's a true etiology or if something else that happened. Regardless, I'll say there was a slight increase in the weight gain as reported. As you can see, about 8% of participants, the dolutegravir 3TC arm, reported weight gain as opposed to just 2% in those who are maintained on ART. Now, is it because of the weight gain in the dolutegravir or because they were withdrawn from any of their previous ART or TDF-based regimens, which may have had a suppressive effect on their weight gain? It's hard to tease out, what that is from, but that's certainly something that we are all watching for. When you looked at significant grade 2 to 5 adverse events, were quite comparable. And of note, when you look at the drug-related AEs, about 20% in the switch and 6% in current ART, weight gain seems to be the most significant. But, did any of these adverse events really lead to withdrawing from the study? Was it bad enough? And in those, there were a couple. 3 withdrew from the dolutegravir arm because of psychiatric reasons. There was 1 death felt not related to study treatment, and there was 1 that was weight gain increase. Now, interestingly, there was also psychiatric, symptoms reported in the placebo arm as well, but these are small numbers. So it's hard to tease them out. The take-home message, when I see it, I feel like the adjusted mean weight change was slightly increased with dolutegravir, about 2 kilograms versus 0.6 kilograms. And I know this is kilograms, not pounds, something that we are more accustomed to seeing. So if you multiply that by 2.2, it gives you an idea of about 5 pounds or so weight gain more in the dolutegravir arm compared to the current ART. And there was also a slight change in the BMI. Again, maybe not statistically significant yet, but these were at week 48. As expected, the markers for proximal renal tubular function and bone markers favored dolutegravir, particularly if participants were coming off TDF-based regimens. But changes in estimated GFR by cystatin C, which is a marker used for renal dysfunction, were similar between the 2 treatment groups. So we have these 2 kind of interesting switch studies in slightly different patient populations, in suppressed adherent populations. So, let me ask my colleagues. So, Eric, when do you use the 2-drug dolutegravir 3TC combination? Then, are there groups that you are cautious about using it?
Yeah, so these studies are great. Obviously, we learn a lot from these kinds of switch trials, and probably one of the most common things we do in clinic now is modify therapy in people who are stably suppressed. So it's wonderful to have these kinds of options. I do think it's really important as we talk about both of these studies to sort of remind everybody that this is a little bit more complicated than a simple switch with regards to what's going on metabolically and with weight. So like in TANGO, it's really tempting to say, well, you're going to TAF-based regimen, going to dolutegravir 3TC. What a great opportunity to find out what happens when you take away TAF. But in reality, that's not what the study did. It took a bunch of people who are on TAF with a variety of other regimens, included boosting agents, and switched them not just to a regimen that didn't include TAF, but also to a non-boosted integrase inhibitor that we know is generally lipid neutral and may or may not have properties of weight gain as we try to sort all of this out. So it's a little complicated as to what's driving some of the changes in metabolics, renal, and weight, because we're taking people off of one drug, perhaps an NNRTI that maybe is associated with weight loss and putting them on a drug that's either associated with weight gain or neutral, like dolutegravir. And, the TAF, everything is changing. The good news is you can do it and it's safe. But I don't think from either of these studies, including SALSA, same issues. It's just that it wasn't all TAF-based, but they were on a variety of other things and then ended up on this simplified regimen. I just don't know that we've answered all the questions. Other than that, we can safely do this, that it maintains virologic suppression in the majority of people who obviously don't have underlying or concerns about underlying 3TC resistance. And there are probably some favorable benefits associated with it, just like we'd seen in other trials, switching from boosting agents to integrase inhibitors. So with that background, how do I use it? Well, we do have an increasing number of people who are choosing dolutegravir 3TC as a regimen for treatment-naive patients who have the viral loads of less than 500,000, for example. And then we have the people who are on these 3-drug regimens without any history of virologic failure, who, for any one of a number of reasons, perhaps we don't want to have them on tenofovir-based therapy or an abacavir-based therapy. We certainly have probably a lot of people who are on dolutegravir, abacavir, 3TC, who, if for no other reason, are saying, gosh, can I do something that will reduce the size of the pill? This is a great opportunity to do that, right? So there are lots of reasons to do it. I'm not sure there are overwhelming reasons for the majority of people to do it, but I think for select individuals, it makes a difference. And it does come at a little bit of a lower cost. We don't tend to think a lot about that in our practice, but it is a little bit less expensive than the traditional 3-drug regimen. So I think that's how we're using it, either upfront or switching in people who are looking for a smaller pill or looking to get off tenofovir because of progressive decline in renal function. Occasionally, and I'll finish, and then I'll let you weigh in on this issue because it's really a big one for our patients and for practitioners. We do have these people gaining weight on integrase inhibitors and TAF-based regimens. And they've read about, and we talked to them about the emerging data that suggests that TAF and second-generation integrase inhibitors may be associated with increased weight gain. And they're asking questions about switching. And we tell them that we have no data. There are studies going on trying to look at that, but dropping the TAF might be a simple, easy thing to do, supported by clinical trial data, if it's something they really want to try. So that's sort of where I am. Tell me what your experience is in your clinic.
It's interesting. A lot of my patients who are suppressed remain inherently fearful of any change. The ones that, because if I can take my pill, and for the most part, most patients are actually down to 1 pill a day, for the majority, right? Because I think you have enough single pill combinations that it's not an issue. And so for them, and they really would be the ideal person. The people who are looking to change are my intermittently adherent group, people who are not fully adherent because, for side effects or so. And I'm not sure that these data actually address those patients, because this is really looking for people who are virologically suppressed with no previous virologic failure. So I think when you have those group of patients, particularly, I think if somebody had dyslipidemia or something, now we don't have the data to support that, but I do have people who are tired of taking more pills. And if they were on a TAF-based regimens, could this perhaps reduce their need to be on a low-dose statin or something and hence reduce the pill burden? That might be something that people might be interested in. We haven't seen the evidence to see that actually is supported, but that is something my patients are asking for in terms of reducing the number of pills and other medications that they want to take.
You make a really important point, and I think we can't emphasize this enough as we get more and more comfortable making switches in the clinic, that there are risks. And certainly we don't want to do this in someone that we think may have underlying 3TC or FTC resistance. But the other group that it hasn't really had a stress test are those people with borderline adherence, right? And we have a lot of those people, right, who are on a 3-drug regimen, admit to missing 1 or 2, and that might mean 3 doses a week, and are always undetectable. Because these drugs, we don't like to tell our patients this, but they're pretty forgiving. Yeah. But we don't know that that's true with a 2-drug regimen. So we do need to be really careful and select wisely who we make these switches to.
Wonderful. Thank you very much to Drs. Daar and Swaminathan, and thanks to our listeners for joining in. As a reminder, to view the full educational program, Contemporary Management of HIV 2021, on the Clinical Care Options website, please click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.